S.Guhan. Parvovirus in the kidney transplant recipient, our experience.
A very good afternoon to one and all. I am Dr. Guhan, presenting a case of a parvovirus infection in a renal transplant recipient. So starting from his pre-transplant history, he was Mr. R who presented in 2012 with a road traffic accident to our hospital, and in this admission he was diagnosed to be RVD positive. He was started on antiretroviral therapy with tenofovir, lamivudine and efavirenz based regimen. However, he had poor compliance to the drug therapy and he resorted to native medications. 7 years later, he presented again to us with proteinuria and renal failure with a creatinine of 1.9 mg per deciliter. He was planned for a renal biopsy, which however he was not willing, and he continued the native medications. 1 year later, he presented to us with multiple abscesses, severe anemia and end-stage renal disease. In view of the severe metabolic acidosis, he was initiated on renal replacement therapy. His ART was switched to an abacavir, lamivudine, dolutegravir based regimen, and he continued to be on dialysis with us at a frequency of thrice weekly. At this point of time, he was evaluated. His mother came forward as a prospective donor. His CD4 count at the time of evaluation was 254 cells, and his HIV load was undetectable. So following a detailed workup, he underwent an ABO-compatible transplant in May of 2022 with besiliximab as induction therapy and triple immunosuppression regimen consisting of CNI, antimetabolite and prednisolone. He had an immediate graft function with a creatinine of 1 mg per deciliter. In the immediate post-transplant period, in post-operative day 9, he had transaminitis which was unexplained with an elevation of OTPT as well as alkaline phosphatase. His total bilirubin, direct bilirubin and PTNR were normal. Ultrasound of the liver was done, which is also normal. His serology was evaluated. IgM for hepatitis A, hepatitis E was negative. HBsAg was also negative by ELISA and anti-HCV was also negative. HCV RNA was also done, which was also negative. Although this did not fit in the actual timeline, CMV PCR was evaluated in view of the immunocompromised state and this was negative as well, and a fibroscan revealed normal reports. So because of the possibility of new drug introduction to his prior regimen, the possibility of a drug-induced liver injury was considered. We reviewed literature and we identified that there is a possibility of interaction between abacavir and MMF, wherein the abacavir increases the intracellular concentration, whereby it causes hepatotoxicity. And because at this point in time his CD4 count was 501 and his HIV load was not detected, we went ahead with withholding the ALD regimen for 2 weeks. And on follow-up, his transaminitis resolved. His hemoglobin was 9.8 grams at this admission, his creat was at 1.07 milligram per deciliter. After the 2 weeks and after resolution of the transaminitis, he was restarted on the ALD regimen. 3 months post-transplant, he was admitted to us with gastroenteritis and an acute graft dysfunction. His creatinine at this presentation was 1.8 milligram per deciliter. His tacro levels showed of more than 30 nanogram per ml. Initially, he was on tacrolimus of 2.5 twice a day with an intermediate metabolizer. However, at this admission, his tacro levels showed an increase to around more than 30 nanogram per ml. So because of the sudden rise in tacro levels, we just went through his treatment protocol and his prescription again. Surprisingly, we identified that there was an inadvertent change in his antiretroviral therapy prescription due to some logistic issues, wherein he was started on a protease inhibitor for a short period of time. So luckily, we identified that within the first week of the change in prescription, and we restarted him back on the ALD regimen. And his tacrolimus dose was reduced to 2 milligrams twice per day. And in this admission, he was also identified of NODAT and he was started on insulin. And on follow-up, his tacrolimus levels were 5.2 nanogram per ml. 4 months post-transplant, he presented with complaints of fever for 4 days with severe myalgia. On evaluation, found to have a severe anemia, hemoglobin of 5.3 grams with a total count of 5,300 and platelet of 85,000 with an MCV of 92. His LDH was slightly elevated at 884 units per liter. A peripheral smear was done which showed a normocytic normochromic anemia, mild leukopenia and occasional giant platelets with a reticulocyte count of less than 1%. His CMV PCR was again repeated, which was also negative. There was no transaminitis at this admission. There was worsening anemia and worsening leukopenia. The NADRI total count dropped up to 1,190 cells per millimeter cube. Owing to this, MMF and cotrimoxazole was withheld, and he was started on injection filgrastim of 300 units subcutaneous for 3 days. And he was also supported with iron supplements and 5 units of packed cell transfusion. So, despite the transfusion and the supplementation, the hemoglobin initially improved up to 7, dropped back to 5.1 within a week with a slightly elevated LDH count. So owing to this, we went ahead with a bone marrow biopsy, and a bone marrow biopsy showed a hypercellular marrow with reduced tri-lineage hematopoiesis with feature suggestive of an aplastic crisis. We also worked up at this period of time for the possibility of a parvovirus infection, and parvo RT-PCR was detected at more than 1 lakh copies per ml. He was then managed with injections of IV immunoglobulin of 25 grams over 5 days, the dose being 2 grams per kg over the course of 3 to 5 days. And post this therapy, his total counts improved to 5,800 cells, his hemoglobin was 7 grams and platelet was normal at 2.3 lakhs. Iron study showed an elevated TSAT, so further iron supplements were withheld and he was asked to follow up after 1 month. However, 1 month on follow-up, his hemoglobin again dropped to significant levels of 4.1 grams. At this admission, he was again supported with 2 units of Paxil transfusion. However, in view of the relapsing anemia and probable relapsing parvovirus infection, the second course of IV immunoglobulin was given at 125 grams. Repeat parvo titers were done, which again showed levels of more than 1 lakh. So even at this follow-up, tablet MF was not restarted and he was continued on the same dose of immunosuppression of 2 milligrams twice a day tacrolimus and prednisolone of 10 milligrams per day. An infectious diseases consultant opinion was obtained, and what they opined was to support the patient with Paxil transfusions as and when required when he had symptomatic severe anemia, to watch for the relapse of the disease and to probably go for monthly prescriptions of IV immunoglobulin, and thirdly to maintain the lowest possible stable dose of immune suppression to maintain a normal graft function. When this was followed up, his hemoglobin was 7.3 grams. So the final diagnosis was retroviral disease on antiretroviral therapy, basic disease being a probable HIVAN. He was an ABO-compatible live-related renal transplant recipient with immediate graft function with NODAT and a refractory severe anemia responsive to 2 courses of IV immunoglobulin secondary to parvovirus infection. So moving on to the evaluation of post-transplant anemia, just like how we evaluate the pre-transplant period, most common causes need to be ruled out, and these remain iron deficiency and anemia secondary to acute as well as chronic blood loss. In addition, in a patient who's been on dialysis and has been moved on to renal transplant, untreated hyperparathyroidism also needs to be evaluated. With regards to evaluation specifically in the transplant setting, specific drugs such as ATG, MMF, azathioprine, mTOR inhibitors, and antiviral agents such as ganciclovir and valganciclovir have also known to cause significant anemia. In addition, ACE-ARB therapy and specific diseases such as thrombotic microangiopathy can also cause anemia in the post-transplant period. Rare causes such as passenger lymphocyte syndrome also need to be evaluated, but more commonly in the first to 6 month period, viral infections such as cytomegalovirus, HIV, EBV, and in our patient, parvovirus are more common causes in this timeline. Moving on to parvovirus. Parvovirus is a non-enveloped single-stranded DNA virus. It is named from the Latin word parvo meaning small. These are the smallest DNA viruses identified at that period of time. This was discovered by Professor N.Gopalakrishnan, who when evaluating samples for serology for hepatitis B, incidentally identified a particular sample which showed these viral particles. So this was from batch B, sample number 19, owing to which it came to be known as parvovirus B19, and so far only humans have known to be the only pathogenic host for parvovirus B19. The route of transmission is aerosol spread, and the morphology of the virus, the capsid proteins are the viral protein 1 and the viral protein 2, which trigger the initial immune response. In addition, the non-structural protein is also seen to play a role to development of the immune response as well. Similar to other single-stranded DNA viruses, it undergoes the same life cycle wherein it has attachment to the cell surface, it undergoes penetration via endocytosis, goes in for uncoating, has replication of DNA, transcription to RNA and protein translation, followed by assembly of the virions, and when the cell undergoes lysis, these virions are then released into the circulation, which can infect further cells. Regarding the immune response, the earliest response, as we know, is going to be the humoral response to the virus. This happens by an early IgM response and a longer lasting IgG response. And secondly, although the humoral response is what combats the acute parvovirus infection, it is the cell-mediated immunity which plays a major role in clearing the cellular reservoirs which tend to cause chronic infection as well as those that cause the relapses. Clinical presentation, most commonly it's seen to be asymptomatic. This is seen in many population-wide seroprevalence studies wherein around 20% of patients in the general population have also seen to be positive for antiparvovirus antibodies. And in children and infants, it can present with fever and an exanthematous rash called as the 5th disease or erythema infectiosum. In adults, it presents with multiple joint pains and swelling similar to the presentation of rheumatoid arthritis. They say that the pathogenesis behind this arthropathy in parvovirus is that it is due to deposition of the immune complexes in the joint spaces. So that's why they say that this is more common in immunocompetent adults, and in immunocompromised individuals where there is a lack of an antibody response, this arthropathy is rarely seen. In addition, predominantly the hematological manifestations start off as a transient aplastic crisis wherein the parvovirus can literally turn off the bone marrow for a period of around 10 to 14 days. And this, if it is for a prolonged period of time, can result in a pure red cell aplasia. In special populations such as in pregnancy, this can present with hydrops fetalis causing intrauterine death as well. This is the clinical course wherein the patient initially presents with fever, chills, headache and myalgia, followed by the onset of rash and arthralgia in the second week of the illness. Hematological changes are seen by a drop in the reticulocyte count, which is where the bone marrow actually tends to turn off due to the acute infection, and then the drop in hemoglobin, which is where we generally tend to identify this anemia and identify the infection. Diagnosis is by evaluation of the parvovirus PCR levels, which this is the period of viremia, so this can be identified even at the early first week of illness. And the serology, IgM, starts to generally peak within the 7th to 10th day, whereas the IgG response is more commonly seen in the 3rd week of illness. With specific interest to the kidney transplant recipient, various studies have shown incidence rates varying anywhere between 1 to 12%. What is important to note is that there is a lack of classical symptoms in a patient with renal transplant recipient, wherein they do not have these fevers or these joint pains. And the evaluation for an acute severe anemia or a chronic persistent anemia generally reveals an incidental parvovirus infection. When evaluated, the peripheral smear generally shows a normocytic normochromic picture which is resistant to erythropoietin therapy. So although as explained earlier, it is a diagnosis of exclusion, it is very important to have a high index of suspicion in any kidney transplant recipient. Moving on to the pathogenesis, they say that collapsing glomerulopathy has had direct implications and direct proven causality with regards to parvovirus infection. However, TMA mediated, as well as there are some studies which have reported a direct possibility of a direct cytopathic effect causing graft dysfunction. However, up till now, there has not been any proven role of a parvovirus infection causing acute rejection. Moving on to HIV and parvovirus, the main problem with HIV is the lack of the protective antibody response. So the IgM response is deficient. And just like in a kidney transplant recipient, it is a diagnosis of exclusion. So after you rule out the more common possibilities such as anemia of chronic disease, deficiency secondary to vitamin B12 or iron, opportunistic infections such as Mycobacterium tuberculosis and pneumocystis jirovecii pneumonia, HIV-related bone marrow suppression and AIDS-associated malignancies. Also, secondary to antiretroviral therapy, predominantly zidovudine-based therapy. After you've ruled all these out, it is important to have a suspicion for the possibility of parvovirus infection. However, one good thing to note is that it is seen to have good response to IV immunoglobulin therapy. The therapy, they say around 80 to 90% of patients respond very well to the initial course of therapy itself. However, the problem, as we spoke about earlier, because of the low CD4 count and the inefficient lymphocytes, that tends to be the parvovirus residing in cellular reservoirs. So there tends to be a high risk of relapse owing to the persistent low level of viremia despite adequate treatment. So this is what causes the chronic persistent anemia, even when there is a response to the initial treatment. So treatment options, first important thing, as we said, because of the spread of road through the aerosol spread, it is important to isolate such patients because in a normal immunocompetent individual, this does not cause severe infection. However, as we tend to admit all our transplant patients in the same ward, it is important to make sure that you isolate them from other immunocompromised individuals. So isolation is the first step. Second is supportive management with packed cell transfusions and iron B12 folate supplements. But the most important treatment, and the specific with HIV as well as immunocompromised patients such as renal transplant recipient, is immunoglobulin therapy at 2 gram per kilogram over a course of 3 to 5 days. Another important thing is to modify the immunosuppression, as we saw in our patient, to maintain the patient at the lowest possible dose to make sure that there is no graft dysfunction. In addition, there are a few case reports of switching from a tacrolimus to a cyclosporin-based therapy which have shown benefit in early clearance of the virus. And in immunocompromised individuals, there is always a high risk of relapse. So repeated courses of IVIG, with some studies saying repeat course up to 6 months or 12 months of monthly IVIG courses may be required. And in patients with HIV, as the CD4 is seen to be a surrogate marker with regards to the clearance of the virus, monthly monitoring of the CD4 counts is also very important. Future research, they say that screening of blood products prior to transfusion in both infants as well as immunocompromised individuals for parvovirus B19 is recommended. In addition, alternate therapeutic options such as cidofovir, brincidofovir and hydroxyurea are also being evaluated with studies on even for a recombinant vaccine at present. Moving back to our patient, our last follow-up was this month when he was admitted with difficulty in voiding of urine and an acute graft dysfunction. He had Klebsiella UTA found to have a proximal ureteric stricture. DKV PCR was not detected. For this admission, antigrade DJ stenting was done. His last creatinine is 1.2. His hemoglobin is 7.3 gram per deciliter at last follow-up. He has not received IVIG for the last 2 months now. He is currently on tacrolimus and prednisolone-based immunosuppression and an abacavir, lamivudine, dolutegravir-based ART regimen with a CD4 count of 486 and HIV load is not detected. So although right now his anemia is under control, there are chances that he could go in for relapse. So we are having close monitoring of the hemoglobin as well as the CD4 count. Finally, about our experience over the last 1 year. So apart from this, we've had 3 other patients with parvovirus infection over this last 1 year. Well, first was a 16-year-old male who was a live-rated renal transplant, who 1 month post-transplant presented with graft pyelonephritis, anemia, thrombocytopenia and graft dysfunction, new onset seizures. MRI revealed a left temporal contusion and a tentorial SAH with diffuse pachymeningeal thickening and a frontoparietal flare hyperintensity. For evaluation of the anemia, it was done and it showed a parvovirus PCR was positive in the serum, although the CSF panel was negative. He was treated with IVIG and lowering of immunosuppression and he responded well to treatment. The anemia improved. The second patient was a 65-year-old male who was again live-rated renal transplant. 1.5 years post-transplant, he presented to us with fungal sinusitis and CMV infection. However, in view of persistent anemia, he was also evaluated for parvovirus, found to be positive, and he improved just with lowering of immunosuppression, so he did not require any IVIG therapy. The third patient was a 45-year-old male who was a live unrelated renal transplant done elsewhere, who presented 3 years post-transplant to us with NODAT and a recent CMV infection. He was admitted in a very critical state with sepsis, multi-organ dysfunction and pancytopenia. For evaluation of the pancytopenia, again parvovirus PCR was done, which is also positive. However, he succumbed to septic shock and he died. Thank you.
We have a facility for chronic maintenance dialysis of patients with HIV and DSRD from 2013 onwards. So he was very well preserved and his retroviral status was well under control. He satisfied all the prerequisites for going for transplant and there was a living donor in the family, so we went ahead transplant, everything was fine. But the things of that and the point is that the protease inhibitor should not be given along with CNI. It's not contraindicated, but it's very difficult to manage. Sometimes, the protease inhibitor, it's enough if you just give 1 or 2 milligram of tacrolimus once in 10 days or something like that. Such is the drug interaction. Very difficult to monitor. So he was not on the protease inhibitor, it was a different kind of regimen. And also, abacavir interaction with MMF was new knowledge for us, actually we learned that. And that caused mild liver injury and that resolved well with that. Everything was going smooth, but suddenly this severe anemia, it turned out to be unfortunately parvovirus. The parvovirus, when we read about the clinical presentations, varied presentations, like one of the patients has experienced it can cause nervous system involvement, not just, it is very often referred to as an important cause for pure exhalation and then pancytopenia. Beyond that, we have been looking for parvovirus in the past also whenever we came across a post-transplant collapsing lung as a kind of investigation panel. But we have really picked it up. So, but now we have our own facility in GH for parvovirus. Wherever there is a clinical suspicion, we are just looking for it. But the treatment is very expensive. Already 2 courses he has received, we were able to kind of overcome the problem and now his hemoglobin is stabilized around 1.28 grams. But in future, what will happen? Because I think it seems that eradication of parvovirus, I think it is impossible in a kidney transplant recipient, as long as they continue immunosuppression. Now also he is not a member, because immunosuppression is very minimal, only CNI and prednisolone. The problem is that we don't dare to bring down the immunosuppression further also because HIV, patients with HIV, they stand at a high risk for acute rejection. It's a kind of a paradox. HIV being, even though it is a kind of immune compromised state, brings down the immunity, but the HIV patients, the reported incidence of acute rejection is about 30%. And there are many explanations for that, including the homeostatic expansion of the T cells and so on. So beyond that, if you reduce immunosuppression, the chance of rejection is there, and if you escalate or continue at this level also, there is a chance that there can be a relapse of parvovirus flare. Any opinion? Probably, if we keep on looking for parvovirus in most of the clinical situations, we may be able to pick it up more, I think.
We had parvovirus causing thrombotic fracture.
Thrombotic.